I'm Katie Renati, one of the volunteer leaders of the Northern California support group. 6 years ago, when our AXYS son was in sixth grade, he started experiencing school anxiety and depression. We were really concerned about him and didn't know what to do and who to talk to. Fortunately, we were able to meet with Dr. Hong at Stanford. He helped us through a difficult time, and his experience with other XXY children was extremely valuable. In addition, he connected well with our son. Today, it is therefore my great pleasure to introduce Dr. David Hong, who will talk about how to cope with the most common behavioral conditions in children, anxiety. Dr. Hong is assistant professor of psychiatry and behavioral sciences at Stanford. He's part of the Center for Interdisciplinary Brain Sciences Research at Stanford School of Medicine. Dr. Hong has published many research articles related to X and Y variations, including one I used to share with my son's teacher to help them better understand XXY and why he was struggling so much at school. Thank you, Dr. Hong, for spending part of your Sunday with our group.
All right. Hello, everyone. My name is Dr. David Hong, and I'm a child and adolescent psychiatrist at Stanford University School of Medicine. I'm thrilled to be joining you all again today virtually. It's always a pleasure to come to the AXYS Family Conference. And today I'm going to be talking about coping with anxiety disorder, a very common condition, and hopefully will be helpful for the audience today. Before we get started, just to cover really quickly my disclosures, I do receive grant funding from the National Institute of Mental Health, and I also do some consulting to a parent organization called Little Otter. So for today's agenda, I'm going to spend the time really elaborating on what anxiety disorder is to try to understand what are the symptoms in the general population. And then we'll dig a little deeper in some of the literature and what we know about how common it is and how it might look in children and adults with X and Y variations. I also really want to make sure that today's talk is concrete and practical. So we're going to discuss treatment strategies for anxiety disorder. And hopefully by the end of this talk, either as an individual or a parent, you'll be able to have a sense of how to navigate a clinical setting if you do get diagnosed with an anxiety disorder, and to have some understanding of what we know about treatment interventions in this condition. So, anxiety disorder, what is it? Anxiety is extremely common, as is worry, and it really is different from what we just consider normal worrying. So if we think about worrying as a reaction or a way we manage stress, so anything that's unknown or anything that's happening in our environment, that is what we do all the time. And that's how we sort of get from point A to point B on a daily basis. On the other hand, when you think about clinical anxiety, it really represents a level of worrying that has a significant impact on how we do function in our environment. It's important to realize that anxiety disorders are extremely common. So it is the most commonly diagnosed mental health condition in children and adolescents. And what we know about its incidence globally is that roughly 7 to 8% of all kids will have a diagnosis of an anxiety condition or meet the diagnostic criteria of an anxiety condition. And that's even higher actually in adults. So up to 18% of adults would also meet criteria for an anxiety disorder. In clinical settings, we use something called the DSM-5. That's the Diagnostic Statistical Manual. And it's really a way for mental health providers to have some kind of consensus around what these diagnoses mean. And there's a couple of different ways we categorize anxiety. One is something called generalized anxiety disorder. There's also social anxiety disorder. You may have heard of separation anxiety disorder and panic disorder, as well as something like obsessive compulsive disorder. For the purpose of today, we're really going to focus on the first three: generalized anxiety disorder, social anxiety disorder, and separation anxiety disorder. So really just to walk you through the categories so we're all on the same page of what these different terminologies even mean. Generalized anxiety disorder is the presence of excessive anxiety and worry about a variety of topics, events, and activities. And this worry has to occur on more days than not for at least 6 months. And it's clearly excessive compared to what most people might expect for the content. The worry as it's experienced is very challenging for individuals who are affected by it to control. And this can easily shift from one topic to another. Often, these symptoms are accompanied by at least 3 of the following physical or cognitive symptoms. So in children, the one exception is that only one of these symptoms is really necessary for a diagnosis of GAD. This includes edginess or restlessness, feeling easily fatigued or tired, having difficulty concentrating, or feeling like your mind is often blank. It may be associated with feelings of irritability and other physical symptoms like muscle aches or tension or even soreness. And it can also come up as difficulties in sleeping. So that's anything from trouble falling asleep, restlessness or staying asleep, or having lack of satisfying or restful sleep. Social anxiety disorder is also very common. And as you can guess from the name, it's really any kind of worries or anxieties related specifically to social situations. So you might have marked fear or anxiety about one or more social situations where an individual is exposed to possible scrutiny by others. That might be something like having a conversation, meeting new or unfamiliar people, performing in front of others or speaking in front of others, and being observed. In children, there is a clarification that the anxiety must occur in peer settings and not just in interactions with adults. And, that may make sense because it may be developmentally appropriate for children sometimes to be fearful adults, especially at a younger age. As part of this diagnosis, it's also important to note that individuals will fear that they'll act in a way or show anxiety symptoms that are going to be negatively perceived by others, and that social situations almost always provoke fear and anxiety. They also often demonstrate avoidance or extreme intense fear and anxiety in these social situations, and that others judge that this fear or anxiety is out of proportion to the actual threat by the social situation or the social cultural context. Again, these symptoms need to be lasting for at least 6 months or more to have this diagnosis as well. Another condition is something called separation anxiety disorder, which we often see in younger children. And this is a developmentally inappropriate and excessive fear or anxiety concerning separation from those to whom the individual has an attachment. And you need at least 3 of these following symptoms, including having recurrent or excessive distress when you're experiencing or anticipating separation from home, excessive worry about losing major attachment figures or harm coming to them, so worrying about illness or car accidents, things like that. Persistent and excessive worry about experiencing an untoward event that causes separation. So having irrational fears about getting kidnapped or something of that nature. And then also behaviors, having a persistent reluctance or refusal to go out, away from home, go to school or to work. There may be an excessive fear or reluctance about being home alone or in other settings without their attachment figures around. And this can also include things like a reluctance or refusal to sleep away from home or go to sleep without being near a major attachment figure. There may be repeated nightmares with a theme of separation, or complaints of physical symptoms when separation is anticipated or when it occurs, such as getting dropped off at preschool or for kindergarten. And again, there's a time component for this diagnosis. So fear or anxiety or avoidance, which lasts at least 4 weeks in children and at least 6 months or more in adults. So we talked about the different anxiety disorder conditions in just the general population. And I wanted to drill down a little deeper in what we know about it specifically in X and Y variations. So what do we know? Most of the literature is really in 47XXY or Klinefelter syndrome. So this is the best study. And you'll recognize a lot of the names of the authors or investigators who are doing this work, as many of them are speaking here at AXYS as well. And this is a paper that came out a number of years ago by Dr. Tartaglia's group. And what you can see here is that there's a number of different parent scales or survey assessments where they look at different domains that correlate to mental health diagnoses. And the one that we're going to focus on right now, in addition to things like hyperactivity, aggression, conduct problems, depression, somatization, attention issues, we're really interested in anxiety for the purpose of today's talk. And the way a lot of these scales work is you have a distribution of scores. So something around 50% be the mean of what is happening in your group. And then in this particular instance, scores in the higher range indicate answers of increased struggles with anxiety. So a couple key takeaway points here. A lot of kids who may have a 47XXY or Klinefelter diagnosis are doing perfectly fine without really any symptoms of anxiety. So in this particular study, that's roughly 70% of the boys. And then in this white category, you'll see about 15% of these boys have something in the subthreshold category. So meaning they have some symptoms of anxiety that may not meet full criteria for an anxiety condition. And then roughly 14 or 15% of these kids actually meet full criteria for what would be considered an anxiety disorder. This is pretty similar in other samples of kids with anxiety conditions. So also in a Dutch sample of 6 to 19-year-old boys with KS, they found again, roughly 18% of the kids met criteria for generalized anxiety disorder, either currently at the time of the study or in the past. And then another, 14% of their group had separation anxiety when they're at a younger age. And again, this is a paper that was published roughly 10 years ago in pediatrics, 20 years ago or so, 10 years ago. Shifting from kids and adolescents into adults, there also has been some papers of adults with KS. Here's one from the Danish group, and the Scandinavian countries often have fairly good registry data where they can follow in a national database the outcomes of the entire population. And they also found that in adults, individuals with KS were reported to have significantly more anxiety and depression symptoms compared to other controls who did not have 47XXY. They reported some relationship of these traits with temperamental characteristics. So we have sort of these big 5 temperament traits. And if an individual identified more on the neuroticism scale, then they might have an increased risk for anxiety, particularly in 47XXY. And you can see here, this is a distribution, again, of various mental health domains. And the black line here is adults with Klinefelter syndrome. And across the board, they're reporting relatively higher scores in these domains, whether it's anxiety or depression, compared to individuals who don't have Klinefelter syndrome in this light gray line here. And this dashed line represents when the scores are exceeding what would be considered a clinical cutoff. So again, it's reflective of what we saw in the kids, is that there's a lot of distribution. So a lot of individuals who have this mean score here right at that clinical cutoff of anxiety would still have scores that really don't meet the threshold. And then there's probably a higher percentage of people, adults with KS, who do have scores above the threshold. And this is in contrast to adults without KS who are more in this 50 percentile range. And while most of the research is in Klinefelter syndrome or 47XXY, there have been a few smaller studies in other X and Y variations, and I just want to highlight that. So, there's also commonly we'll hear about 47XXX or XXX, so girls who are affected with an additional X chromosome. The studies are actually very limited in this group of kids, and the sample sizes are quite small. So it's harder to take away and feel really confident that these studies represent the larger group of girls who have this genetic karyotype. However, if you do look at the data, it does seem that rates of anxiety may be elevated in this group of girls as well. And again, thinking back to the general population, where we think of anxiety disorders as being roughly 7 or 8%, in girls with 47 XXX, you might see it as high as 20% roughly. The data in XYY, 47 XYY, so boys who have the additional X chromosome karyotype, the results are more mixed. There's some reports of increased anxiety, again, at this very similar threshold of roughly 20% here. One paper quotes it at 26% of this group will have a increased meet criteria for an anxiety condition. But there's also other reports where they don't see a significant increase in anxiety in this karyotype. And it's interesting to note that because across the board, most of the studies still report increases in things like ADHD or ASD, which makes you wonder if some of these conditions are more consistent across these X and Y variant trisomies, and others like anxiety perhaps are not as pronounced versus others. All right, now we're going to switch over to really thinking through what do you do now that you have a diagnosis or you think you have anxiety, either yourself or your child. I want you to have a good sense of what you can do with that information and how to really be actionable for it to be actionable. So an important thing to do as an individual or maybe as a parent of a child who has any of these X and Y variations is really think about what is the impact that all this worrying or anxiety has on day-to-day function. So something that I often tell the families I work with is the core detriment to anxiety behaviors manifests as avoidance, right? And so one thing to look at as a parent is, are there avoidance behaviors that are really interfering with daily functioning? So this might be something like stomach aches every morning, really complaining about not being able to go to school, or having a real difficulty leaving the house. This may be things like avoiding social activities, not engaging with peers as much as you think would be appropriate for their age. Is it interfering with social relationships, family life, not coming down for dinner, not engaging with extended family, any kind of romantic relationships for our older individuals who have any of these diagnoses? So having some degree of self-reflection about, okay, what would I expect for maybe a sibling at the same age, or looking at other kids in that peer group for that chronological age, and making an estimation of whether or not these kinds of worrying thoughts or anxiety behaviors are really impacting their ability to go out and really achieve a lot of things that you would think would be age-appropriate milestones. And if that is the case, it does make sense to try to go ahead and get clinical input to make a formal diagnosis of anxiety. And a diagnostic assessment often happens with a clinical interview and with these symptom scales, like these pen and paper or online assessments that your doctor may ask you to fill out. And a wide range of people are able to make these sorts of diagnoses. And that might be a pediatrician, your primary care doctor, a therapist, a psychiatrist. And when we do make these conditions or these diagnostic classifications, you'll hear again whether it falls into the category of one of the anxiety disorders we just reviewed earlier. And often we'll talk about symptom severity. So whether the symptoms fall in a mild category, moderate, or severe. And if you do fall in one of the moderate or severe categories, this might ultimately result in a referral to a specialist, so a mental health provider, and that might be a therapist or a psychiatrist. And sometimes in the cases where it's really significant, so if you have a child who is fully refusing to go to school and hasn't gone to school for weeks, that might require a more comprehensive intervention. But for the purposes of today, we're going to review really what happens in that mild and moderate category, which we think would apply for most of you guys who may be attending the talk. Really for those mild to moderate categories and also in the severe categories, but for those earlier kind of less severe symptoms of anxiety, the gold standard treatment is talk therapy or psychosocial treatment. And that's really the recommendation. Is it's a good place to start before you move on to things like medication. And the one I'll focus on today is something called cognitive behavioral therapy. And that's because it has the most data out there as far as really being effective for anxiety conditions. And it it focuses on these cognitive and behavioral approaches to different situations, right? And so we might often be put in a situation where we have to navigate something new. And what happens when you have anxiety is anytime you're put in that situation, you have all these automatic thoughts and images that are really intrusive and just happen without you really being too thoughtful about them. Right. And so a common occurrence might be like, oh, I have to go and meet these new kids in my new class at school. And all the automatic thoughts might just kind of come pouring in as like, nobody's going to like me. And I'm just such a loser. And why would anyone talk to me? And it brings up all of these reactions. And this is something from the Beck Institute. So Aaron Beck is the sort of the forefather of CBT treatment. And those reactions to having those automatic thoughts can fall in any number of categories. You might have an emotional category where you're frustrated or angry or sad or depressed. You might have physiological responses. You get really tense. You feel uncomfortable. You have this agitated crawling feeling of wanting to get out there. Your heart rate's bumping up. And you also have these behaviors. So you react by trying to avoid the situation, trying to reduce that level of distress. And that might be things like sitting in the corner, not talking to anybody, not making eye contact, not noticing that people are willing to just come up and talk to you. And it sort of has almost this reinforcing pattern. You know, once you shut yourself down because some of your anxiety behaviors, it might sort of confirm and say, oh, see, look, I was right. It was awful. It was as awful as I thought it was going to be. And then it sort of reinforces that next cycle of anxiety. So the purpose behind something like cognitive behavioral therapy is to really accomplish a number of things. Anxiety is so much about anticipation rather than the reality of what a situation is. So it's really teaching kids, adolescents, and even adults is what are the different thoughts and feelings whenever you enter these new situations? So it also challenges you to think about how these feelings might influence us in ways that sometimes really aren't that helpful, right? How do we have these automatic thoughts and what kind of emotions does that bring up to us? And a core piece here is really learning cognitively how to critically evaluate automatic thoughts and to really challenge and really think through whether these automatic thoughts are actually accurate or whether they're biased in a negative way. And then you learn these skills to correct those biased thoughts. And especially for those of you who have children who have anxiety, it's teaching the families to manage unintentional reinforcements or rewards, right? It's a lot easier as a parent sometimes to be when they have a tantrum or really refuse to do something and cause a ruckus, it's almost better to be like, okay, we won't do it today, or we won't deal with that. And that might actually be reinforcing some of these behaviors in a net negative way. I'm going to briefly touch on medications, and we use medications in kids who have moderate to severe anxiety. And it is often going to be more effective when you use it in conjunction with a talk therapy like CBT. But you might have heard of some of these first-line treatments, and those are things called SSRIs and SNRIs. So serotonin, selective serotonin reuptake inhibitors, things like fluoxetine, that's also called Prozac, sertraline, which is called Zoloft, fluvoxamine or Luvox, paroxetine, Paxil, and venlafaxine or Effexor. And really, these have been around for a number of decades, and we have a pretty good sense of what the safety profile is, and they're often well tolerated. So these are pretty commonly the first sorts of treatments your doctor might recommend if you do need medications for an anxiety condition. Some less common medications might include things like buspirone, benzodiazepines, atypical antipsychotics, things like risperidone, Seroquel, and tricyclic antidepressants. A question I always get, which I'll touch on really briefly before we wrap up, is what do we know now about testosterone and what's the impact of testosterone replacement therapy on anxiety? And there's really been very few studies. So to my knowledge, when I was reviewing this, I think there's still only been about 2 studies in kids, one of which is done in boys with, both were actually done in boys with Klinefelter 47XXY. And it's a chart review, essentially. So it's not a controlled study, which is the way we consider gold standard research to occur, is really matching early on 2 groups of kids and putting one group on testosterone and the other or not. But the one where they just looked back and said, okay, we have a bunch of kids who did take testosterone and others who didn't, some who took it in puberty and some who took it earlier. And this particular group found that there were differences between this treated group who received testosterone in this untreated group. So if you look here, about 60% didn't have any anxiety problems, and the kids who did, and the boys who did not get testosterone of any kind. And then 12% or so were in that subthreshold or borderline category, and roughly 27% had clinical anxiety. In contrast, those who had received testosterone at some point in their treatment plan, there is a much reduced number who had clinical levels of anxiety. So 12% relative to 27%. And then the borderline category was roughly similar, and a much higher number of kids, proportion, did not have any anxiety issues at all. Again, this should be taken with a grain of salt because they didn't really control for who received testosterone or not. So one thing to think about is, why did some boys not need testosterone treatment? And that was a clinical decision and not really a treatment decision around looking at anxiety specifically. There's another study in 2017, again, with a number of doctors who often come to the AXYS meetings, where they looked at oxandrolone and just a low level of androgen replacement in boys who had Klinefelter syndrome. And again, you'll see they looked over time. So their baseline functioning on this anxiety scale, which none of these, importantly, are in that clinical range of severity. But at baseline, you can see over time, there was some decrease in the kids who received this low-level androgen. So it went from 58 down to 55 over the course of 2 years, in contrast to the boys who received a placebo or didn't receive any active treatment, who roughly had the same level of anxieties even at 1 year and at 2-year follow-ups. So one thing to think about is there's a possible response to testosterone in this group. And really the group that has the most traction with this, that's studying it rigorously right now, is the Colorado group. So I'm excited to hear about the results of their studies coming forward. In adults, in contrast, they really didn't find any differences, even in these chart reviews, when they looked back at individuals who had received testosterone and those who did not. So it makes you think about whether there's some time-specific effect early in development with the timing of testosterone that's important to see its impact on anxiety. I'm going to wrap up with this last note. When you're thinking about anxiety, it's important to really make sure or consider how related it is to other common diagnoses in this group of kids who have X and Y variation. So ADHD and learning disorder is also very common. You might see a lot of anxiety or avoidance behaviors in specific contexts around school or learning challenges, and maybe less so in other areas, which might make you lean more towards focusing on educational interventions or ADHD interventions rather than anxiety interventions. And then social cognitive challenges and autism spectrum disorder is also often overrepresented in X and Y variation. So if you really see social anxiety or withdrawal around specific social settings, or a lot of difficulty navigating those settings, or you're seeing less interest or motivation around social activities, you might also consider the possibility that ASD is something that's important for your treatment plan for your child, where you focus a lot more on social skills than maybe anxiety treatment up front. And then, of course, often these conditions happen hand in hand. So you may have a situation where it's both, right? You have both ADHD and learning disorder and an anxiety condition. And in those instances, you may be using multiple of the treatments that we discussed today. So I just want to wrap up there and thank you all for paying attention to the talk. I'm happy to answer questions in the Q&A session. Thank you very much.